All right. We are going to look at the myth that all effective psychotherapies force people to confront the root causes of their problems in childhood. And we're going to do that by exploring, well, what is abnormal behavior, getting to know a little bit more about the DSM, and looking at some early, what would have been therapy. First off, just kind of looking at the idea of abnormal behavior. So, when we talk about abnormal behavior, this is what would get, say, perhaps someone a diagnosis of mental illness. And really, when we're looking and trying to define something as abnormal, we've got three different criteria that we're looking at. Is the behavior deviant, dysfunctional, or personally distressful? So, the three Ds that we look at here. And this maybe looks a little bit different than what you think that it would. So, when we talk about deviant, what we mean by deviant in this case is that it's atypical. It's not something that your average person does, but it also has to be culturally unacceptable. So it's both atypical and culturally unacceptable. So if you take a look at this particular slide, you'll notice that there are this is a picture of a particular culture where part of how they attract the opposite sex is by using elaborate costuming. Now, if you were going to try that here in our culture at UJ, probably not going to get you very far because our culture deems this as unacceptable. Also, when we talk about deviant behavior, we can perhaps talk about Santa Claus and talk about how generally a belief in Santa Claus, while it may be somewhat dysfunctional, it is considered culturally appropriate, even if it is a little bit atypical to believe that, hey, a fat man is going to down my chimney and bring me presents. Then we talk about dysfunctional. Really, what we mean by dysfunctional is that the behavior we're talking about is maladaptive, and that means that it interferes with effective functioning. So, the behavior that someone is coping with keeps them from doing the things that they want to do. So, it keeps them from doing the things that they wish to do. And as a result, they are experiencing that dysfunction. It's not just, we can talk about somebody who has obsessive compulsive disorder, and it's not just that they want things just so or they want things clean. It's that they want things just so or so clean that it's keeping them from doing their day-to-day functioning things because they have to focus on that cleanliness or that order. So it's particularly dysfunctional. And then lastly, in order to get a label of abnormal behavior, we need to talk about it being personally distressful. This, of course, one would suggest, well, there are some instances where someone has something that's deviant and dysfunctional just because they don't find it personally distressful. That could be an issue. But ideally, that is what we're looking for, is that there's that idea of deviance, dysfunctionality, and personally distressful. And that's what's going to get somebody a diagnosis of having an abnormal behavior, say a mental illness. Now, that can still be pretty vague. So, luckily for us in our day and age, we have the DSM. The DSM stands for Diagnostic and Statistical Manual of Mental Disorders. The V after DSM stands for what version we're on. We're on version 5. And this is published by the American Psychiatric Association. And this allows our professionals in mental illness to have a common basis for communicating. It also helps them potentially make predictions. So, for example, when looking up depressive disorders in the DSM, a professional can see how common those disorders are versus looking at other disorders that may be less common. So, when they're seeing particular symptoms and not understanding how they come together, they can look at, well, this disorder is much more common than others, much like doctors do if they're trying to diagnose, say, throat versus, say, lung cancer. This can be of great benefit to the person suffering from symptoms. Understanding what's going on can be a great boon to individuals who may not understand why they feel different or why they experience difficulties that other people don't. One of the concerns, though, within the DSM is that by having these types of categories, this can also create stigma that people who have a diagnosis that's present within the DSM are looked down upon as a result of that diagnosis. Now, we'll talk a little bit about that now. We'll also kind of look at this a little bit later. But this idea of creating stigma is definitely something that we worry about. We don't want to do that. But the DSM does a lot more good than it potentially does harm. That doesn't mean that it's perfect. We do have some critiques with the DSM. The DSM is very much a biomedical model, suggesting that it's kind of written like how psychological disorders are medical illnesses. So that going back to that strep throat analogy, this isn't necessarily a good thing, considering the mind is much more at play in our psychological disorders, and that might lead to potential issues. The DSM really doesn't any emphasize any sort of strengths within their diagnoses, particularly focused on weaknesses. It does have a reliance on some social norms and subjective judgments. We would like to hope that individuals who are diagnosed would receive the same diagnosis regardless of what professional they see, but that isn't always the case. Some of our newer categories, people would like to see more research on with some inconsistencies, and particularly for the DSM-5, some existing diagnoses had some loosened standards, taking away age restrictions, and people weren't necessarily on board with that. I show you these critiques not to say that we shouldn't be studying the DSM and that the DSM-5 isn't very valuable to us, but rather that much like any tool for doing a job more effectively, it's not perfect and there are places for growth. All right, so if the DSM is part of how we are going to be able to give a diagnosis, what happens when somebody has a diagnosis? And really, you're probably thinking, well, isn't that a time for therapy? Well, my question to you is, well, what does therapy look like? Oftentimes the joke that we hear, and it comes from the man who's depicted and sitting in this chair, which is a representation of Freud, is that when we talk about therapy, therapy is lying back on a couch and talking about our problems, right? And oftentimes we talk about those problems, and if Freud was in charge of that therapy, we'd say, oh, well, we talk about our childhood, we talk about the past. That isn't necessarily true anymore. Regular therapy offices are, which this is a couple of pictures of, yeah, they still have chairs and couches, but most of the time people are sitting up and talking about them. And you may talk about the past, but you also are just as likely to talk about the present and the future in a therapy office. So this often leads people to say, well, why do we even talk about Freud in a psychology class today? And largely we talk about him because he adds some great historical context to how far psychology has come, how far therapy has come, and acceptance of mental illness. And also that his one big claim to fame is that he was the first person to suggest that talking about our problems mattered, which is the birth of therapy, that we should talk about our problems and it's going to matter. It's going to make us feel better. So we're going to kind of explore what talking about your problems looked like at Freudian level, and then we'll move into some newer conceptualizations of that. So let's see some kind of fun facts to keep Freud in perspective. So he was born in 1856, died in 1939, lived in Vienna. He would have been classified as a physician or a neurologist, and he did a lot of cocaine. But and I bring this up partly because one of the big critiques of Freudian theory is that a lot of it has a lot to do with sex. This was Victorian times. That's probably why. Also, to give Freud's a little bit more credit, cocaine at the time was considered an over-the-counter medicinal treatment, not the activation to the pleasure center of the brain that we now know that it is. So he wasn't the only one. But this and that Victorian conservative time period can help put a perspective and put some context on his type of therapy, which is what we would call psychoanalytic theory. So, what does that mean? What was psychoanalysis? Where did it come from? Well, it actually didn't even start with Freud. It started with Freud analyzing the patient of somebody else, who was Joseph Breuer. And Joseph Brewer had a patient that they referred to as Anna O. And Anna had some very interesting symptoms. So she would suffer from paralysis, nausea, loss of vision, speech. And then what would happen is that Brewer would have her come into the office and they would talk through different traumas that happened during her childhood. And what Brewer and Freud actually observed in this talking about the problems and talking about her childhood is that as Anna talked about her childhood, that her symptoms would lessen or her symptoms would even disappear. And Freud started to refer to this as the talking cure. And he thought that this talking cure existed because of a principle of what we call catharsis. So, Freudian catharsis is this idea that once we talk through the why, once we talk through the past memories, the particular issues, this would allow someone to release anxiety or other buried issues that would occur, and then they would experience this release of emotion, this release of anxiety. And that release or that catharsis would be what helped the person to heal. So, again, through that talking about our problems, we'd experience catharsis or kind of a release of anxiety and other issues from that talking about our issues. And then we would proceed to feel better. So again, Freud really just suggested, hey, we should talk about our problems and we'd feel better. So does psychoanalysis still exist? The answer is yes, but not exactly in the Freudian psychoanalysis kind of idea. Freud also thought it was very important to focus on that past portion of it. Psychoanalysis today, if you can find it, is still going to be quicker than what Freud thought it was. He thought it was going to be a months to years long process. Um, and also, psychoanalysis today is going to involve not just talking about the past, but also talking about the present and potentially future. But psychoanalysis, in that Freud said, hey, we should talk about our problems and it's going to make us feel better, was definitely a help and pushing us towards therapy. So, if we're not doing a whole lot of psychoanalysis today, what kind of therapies are we doing? So, let's talk a little bit about a different type of therapy, which is called humanistic therapy. And humanistic therapy is based on the framework of Maslow's hierarchy of needs. And that's what's depicted in this little triangle here. And Maslow's hierarchy of needs is a way of pursuing our goals. And it's depicted as a triangle because Maslow originally believed that you had to have the smallest level, so the largest level of the triangle, the base level of the triangle, met before you were able to kind of move up and climb the mountain within that. So if you didn't have your physiological needs met, there was no way you were going to be able to have your safety needs met, and so on and so forth. So let's walk through each of these needs and then we'll talk about how therapy uses this framework. Our first need that Maslow suggested we need to have taken care of is our physiological needs. Our physiological needs are, do we know where our next food is coming from? Do we know where we're going to sleep tonight? Do we have clean water? It's the basic physiologies that we need in order to stay alive. The next phase, the next goal we pursue is our safety needs. Is my world safe and predictable? Do I have a schedule? Do I know, what things are like? Do I have a lock on my door that functions well? Do I feel safe walking around my neighborhood? All of those are about having our safety needs met. So again, the world's predictable. I generally know how it's going to go. I don't feel up in the air about any of these things and going from there. Our next stage is our love and belonging stage. So, do I feel that I have love and am loved? Am I accepted? Do I have people that I feel like I belong with and I get to be myself? It doesn't mean just because I don't have a romantic relationship that I wouldn't meet my love and belongingness needs. Romantic relationships can definitely help, but it also can be about having a loving family or close friends that would allow us to meet those needs. Right. Next stage is our esteem needs. So this is all about our need for self-esteem, our need for achievement, and really competence, and to have our self-esteem and our competence recognized by others. It's one thing for the self to believe, hey, I'm a good and worthwhile person. It's another thing for us to believe that others see us as worthwhile people. And then at the top of the pyramid was what Maslow called self-actualization. And this was our need to live up to our fullest and unique potential. And this is kind of a problem when we talk about this because Maslow really believed that not a lot of us would have the opportunity to get up to self-actualization. Most people wouldn't get to be there, but rather it would be something that we would all be striving for. Now, Maslow did pretty well in his theory of his hierarchy of needs. We know that there are some problems with the theory. One, that it's really not as progressive as as Maslow originally believed it to be. We can have people working on their love and belongingness needs and having very satisfying love and belongingness needs, even if they live in an unsafe area, and they're maybe not so sure of where their next meal is going to come from. So they don't necessarily build upon each other as the way that Maslow believed. Also, we know that it's possible for us average people to pursue self-actualization. And Maslow really didn't think we could. He thought you had to be like the best person, like Mahatma Gandhi, in order to pursue self-actualization. But newer conceptualizations of Maslow's hierarchy of needs suggest that the first four needs, so physiological, safety, love and belonging, and esteem, are often referred to as deficiency needs, meaning that in order to pursue our highest need, our being need, our self actualization, we would be willing to deal with a slight deficiency on esteem, love and belonging, safety, or physiology in order to allow us to pursue that bigger goal of, say, truth and justice or meaningfulness and goodness. I often, when I'm thinking about the newer conceptualizations of Maslow's hierarchy of needs and start talking about being needs, the being need of self-actualization versus the deficiency needs of the other four, I start thinking about Batman because Batman could have a really like stable triangle, right? He knows where his next meal is coming from. He's got lots of money. He's safe. He's got this whole fortress. He could have relationships. People like want to be him. He's a pillar of the community. But Batman chooses to sacrifice basically on kind of all of those levels, especially safety and love and belonging. Batman's relationships never go well to pursue that self-actualization of justice and truth and having a safe area to be in. So this is the background for what we call humanistic therapy is pursuit of this Maslow's hierarchy of needs. Now, within humanistic therapy is often most focused on those belongingness part of the needs as like, how do we belong to others? So let's look at the therapy specifically. When we talk about humanistic therapy, we talk about the source of pathology, who brought it out, and what are the techniques that we're dealing with. Okay, so for humanistic or person-centered therapy, which is what humanistic therapy is talked about as, the belief is that the cause of our problem, any sort of mental deficiency, any sort of illness that we're having, is between results because of an inconsistency between our behavior and our identity. So there's an inconsistency between our behavior and the person we want to be. That is the source of any pathology, any issue that we're having. Um, Carl Rogers was the individual who came up with this type of therapy. And one of his big goals within person-centered humanistic therapy was to promote this idea of active listening. And active listening is the idea that we are kind of confirming to whoever we're having a conversation with that this is what I heard. Is this accurate? So, active text listening is a great technique both for therapists to make sure that their clients are heard, and actually for all of us as people. What we do when we're active listening is someone tells us something. So let's say one of my colleague walks in the office and says, "Hey, I'm having a really horrible day. I was late to work because my car broke down and it won't start and we don't know what's wrong and we don't know how much it's going to be. And I'm really worried about this and I don't even know how I'm going to get home from work tonight." And if I was practicing active listening, what I would say was, you know, it sounds like you've got a lot of stress going on, especially with your car breaking down and not knowing how much it's going to cost or how you're going to get home. Am I right? Is it all about, your car, or did I miss something? So, what we do when we're active listening is we're kind of restating what we just heard from the person we're interacting with, allowing them the opportunity to kind of confirm or deny that we are interpreting things correctly. It's a very validating form of communication. It also helps to minimize any sort of errors that we have within that. Now, humanistic and person-centered therapy is not non-directive. There's not necessarily a clear problem that we're trying to get through, but rather that we're kind of starting to promote some really good belongingness goals and ability to connect with others. Another thing that our person-centered therapists, our humanistic therapists are working towards is promoting an environment where we talk about unconditional positive regard. Unconditional positive regard is the idea that we are creating a environment of warmth and empathy, and there's not disapproval. I always talk about unconditional positive regard. It's what we want from parents, right? So I'm going to love you no matter who you are and what you become. I'm just going to love you even when you screw up. That's the kind of unconditional positive regard we expect from parents. Um, Therapists might be a little bit different, but it's also that, we expect that if a therapist is showing unconditional positive regard, we might tell them something kind of shocking. And they're just like, wow, I'm so glad that you told me this. Thank you for being vulnerable and sharing this with me. So creating that connection. Humanistic and person-centered therapy is great at creating what we talk about positive rapport with clients. So clients really like engaging in this way. So there's some advantages and disadvantages to this. Advantages, it's very acceptable to patients. As I said, patients like engaging in this way. Uh, while you won't necessarily find a lot of humanistic or person-centered therapists who are like only practicing in that area, you'll find that a lot of therapists use these techniques of active listening and unconditional positive regard along with other types of therapy. So it translates, it communicates with different types of therapy very well. And then as a disadvantage is effectiveness, since there isn't always a clear goal with humanistic person-centered therapy, it's kind of hard to measure like, are we really doing what we're supposed to be doing? Because we didn't necessarily have a clear plan of like what we were trying to get rid of or what we were trying to work on in the first place. So this is kind of the place where from this idea of Freud and talking about our problems, this was one of the ways that we now see therapy coming out of that tradition. And as we continue in addressing this myth, we'll talk about more ways that therapy comes out of this tradition.